Ever had a finger that clicks, catches, or locks up bent, so you have to pull it straight with your other hand? That's trigger finger. The medical name is stenosing flexor tenosynovitis, but really it's a mechanical problem. One of the tendons that bends your finger stops sliding smoothly at the base of the digit, on the palm side. It's common, not just an athlete's injury, and it most often hits the thumb or ring finger, though any finger can do it, and sometimes more than one. Here's what's happening inside. Your finger tendon runs through a series of little tunnels called pulleys that hold it against the bone. The first one, at the base of the finger, is the A1 pulley. In trigger finger, that pulley, and sometimes the tendon itself, gets thickened, so the tunnel is now too tight for the tendon moving through it. A small swollen spot on the tendon catches at that narrow point, and when it finally pops through, you get that snap as the finger springs from bent to straight. And this matters for treatment. It's tempting to think it's just inflammation, but in the more stubborn cases the tissue is actually thickened and scarred, the architecture has changed. That's why an anti-inflammatory can ease your symptoms without fixing the whole mechanical problem. Think of it as a spectrum, at one end, an occasional painless click, at the other, a finger that won't straighten at all. Where you sit on that line usually tracks how much the tissue has changed. So who actually gets this, and why does that change what you should do about it? Stay with me. The single biggest link is diabetes, and the longer you've had it, the more likely you are to get triggering in several fingers, and the less predictable an injection can be. Other things show up in the risk picture too: high cholesterol, thyroid problems, kidney disease, inflammatory conditions, and carpal tunnel syndrome. But here's the honest part: these are associations, not proof. They don't mean one thing you did caused it, and they can't predict your personal outcome. What they do tell your clinician is to take a broader history. So how do you recognize it? The giveaway isn't a vague ache, it's a catch at the same repeatable spot every time you bend or straighten the finger. That repeatability tells you more than any one-off twinge. It can start as a small painless click. Then you might feel tenderness on the palm side at the base of the finger, pain when you grip, or stiffness in the morning. As it gets worse, the finger moves unevenly, then needs your other hand to straighten it, and in the end can stick bent for good. Notice that severity is about what your hand can and can't do, not how loud the click is. You might feel a tender little lump near that A1 pulley that moves as the tendon glides, though not everyone has one. And the tenderness is usually focal, right at that crease. Widespread pain with no clear catch is a different story. Before we go further, some warning signs that are not ordinary trigger finger, and mean you should get checked sooner. Sudden severe swelling. A finger that looks hot or infected. New numbness or pins and needles, especially at night. Or a firm lump. If that's you, don't just wait it out. This isn't the routine trigger finger script, and it needs a proper look. Okay, so how does a clinician actually confirm it's trigger finger? It's simpler than you'd think. Mostly, it's a hands-on exam, no scan needed. Your clinician asks which finger catches, whether it happens bending, straightening, or both, whether it locks, and how it's hitting your grip, your sleep, your work. Then they watch you slowly open and close the hand while pressing over the base of the finger, feeling for the catch as the tendon travels. A catch during your own active movement, with tenderness right there, points to trigger finger far more than plain stiffness. One useful check: if you can't straighten the finger yourself but they can straighten it for you, the problem is mainly the tendon gliding. If it's stuck both ways, something else may be adding in. Fair warning, there's no perfect bedside test with a tidy accuracy number, so it's the whole picture that counts, not one move. What about a scan? Ultrasound is an optional add-on, not routine. In a typical case you don't need it. But it can be handy when the story doesn't add up, or there's a lump that might be something else. It can actually show the thickened pulley, the swollen tendon, and even the snap as your finger moves. When it's used well, it confirms what the exam already suggests. Now treatment, and this is the part to get right. It's a ladder, not a podium. There's no single winner. Where you start depends on how bad the locking is, how long you've had it, whether you have diabetes, and how much you'd rather avoid a procedure. One more thing that'll save you confusion: studies measure different things. One counts fewer catches, another counts pain, another counts recurrence. So don't compare success percentages between studies as if they mean the same thing. Start at the bottom of the ladder, because a lot of this you can do at home. First, ease off the exact grips that set it off. You're not freezing your hand, just backing off the moves that make it catch. A splint that stops the joint from driving the tendon through that tight pulley can help too. And here's a simple home routine studied in trigger finger, a finger orthosis plus a tendon-gliding exercise. Move your hand through 4 fist shapes: straight fist, hook fist, full fist, back to straight, holding each for 5 seconds, and a gentle stretch for 20 seconds. Do 10 of each, 3 sessions a day, for 6 weeks, always gently, never pushing into pain. In that study, over about 6 weeks people took their movement pain from around 6 out of 10 down to about 1, with clearly better hand function and roughly a 55% success rate. That's a lot of improvement from something you control yourself. If home care isn't enough, the next rung is a corticosteroid injection, the best studied non-surgical option. A clinician places a small dose of steroid, like 5 to 10 milligrams of triamcinolone, right around the tendon at that A1 pulley to improve the glide, without cutting anything. It's a middle path, more direct than a splint, less final than surgery. It works well early for many people. Triamcinolone cleared the triggering in about 83% of fingers in one study, but roughly a third come back over the following months. Compared head-to-head with physiotherapy, the injection won on early relief, while the therapy group had no recurrences by 6 months. And if you have diabetes, the response can be less reliable, a reason to talk it through, not a reason to jump straight to surgery. 2 more rungs. Shockwave therapy sends acoustic pulses over the sore area across several visits, no needle, no cut. It might help, but the evidence is smaller and more mixed, so treat it as an emerging option, not a proven replacement. At the top is release. The surgeon divides that tight A1 pulley to open the tunnel for good. It can be open, through a small incision, percutaneous through a tiny access, or ultrasound-guided. Open release has the longest track record. The smaller access versions can mean an easier recovery in the right hands. But anatomy, the surgeon's experience, nerve safety, and scarring all matter, so it's reserved for triggering that's persistent, severe, recurrent, or really getting in your way. So here's the takeaway. Trigger finger is a repeatable gliding problem at the base of your finger, not a mysterious sore hand. Watch for the catch that happens at the same spot. Don't keep forcing a locked finger. Start with the home care when it's mild, and get it checked when locking, pain, lost motion, or an odd symptom starts getting in the way. This video is general information, not medical advice for your specific case. Please see a qualified clinician about your own hand. If it helped, subscribe and follow for more like it.